Joining me virtually, Dr. John Campbell from the United Kingdom. Welcome to Daily Detroit.
Thank you, Joe. Thank you for having me. Good to talk to you.
So I have to truly tell listeners that you have been the voice through my screen for 16 months of this pandemic, where I'm like, I need a voice of sanity. I need something international. I need something that isn't just all the mainstream stuff. Even though, I respect a lot of my journalism colleagues, I want different voices. I want to listen to doctors. Listeners of the show know we've had a parade of doctors on this show, infectious doctors, primary care physicians, people on the ground here in Detroit. And so with the rise of the Delta variant, I wanted to talk to somebody who has already been talking about it, because the Delta variant feels very new to us here in the United States, but it's not new around the world, right?
That's right. Well, I'm just a nurse and an academic, but I'm certainly happy to give your questions a go. Delta variant. So in the old days, we used to call these variants according to where they were first discovered. And this one was first discovered in India. Like you might remember, we had that UK Kent variant that was first discovered in the UK, and that was later called the Alpha variant. And then the World Health Organization wanted to start to use Greek letters. I guess it sounds clever and scientific, and it's kind of not stigmatizing a particular area, is what they're saying. So yeah, this Delta variant arose in India probably last year. And it rumbled on in India for a while. But what tends to happen is, after rumbling on for a while, it goes up steeply. You get this exponential rise. So unfortunately, we were carrying on flights in the UK from India. I was bouncing up and down in this chair, as you might remember, saying, "Stop the flights from India. We're going to get this. We're going to get this India variant, as we called it then, now called the Delta variant." They still carried on. It did go on to what's called our red list, but it was much later on. It was all done. That's been a characteristic of this pandemic, Joe. Really, I mean, everything is so many things. Virtually everything has been done reactively rather than proactively. There seems to have been this sort of inability to think ahead, and this is just another example of that. So at the time in the UK, we had this mostly Alpha Kent variant. Now that Alpha Kent variant was about 40% more transmissible than the original wild type variant. So that took over. So that was the dominant variant, well over 90% of cases in the UK. But this Delta variant is about 60% as transmissible again, at least. And in fact, now it's more transmissible than that. People are talking about an R value, this reproductive value for this Delta variant of about 6, which is more than double. It really is very contagious. So basically what happened is, with simple sort of evolution, it outcompeted the old Alpha variant and now has replaced that. And now about 98% of cases in the UK are this Delta variant.
Well, that's a question that a lot of listeners have, because there have been a number of people who've asked me, like, what is the difference between COVID and a variant? I don't think it's exactly clear to people.
Sure.
That they're like, well, it's COVID. What does a variant mean? Because, here in the Motor City, when you say variant, let's say, a model of a Chevy, a variant might have a nicer stereo system, or better tires, or something like that. But this is a much different situation.
Yeah. So SARS coronavirus 2 is the virus, severe acute respiratory syndrome virus type 2. And that's to differentiate it from a virus that popped up back in 2003, which was SARS, which I guess we would now call SARS type 1. The disease that the SARS coronavirus 2 is the COVID-19 coronavirus disease, first identified in 2019. So we did have a big pandemic back in 1819, but that was a different one. That was an influenza one. So what happens with this virus, that there's about just under 30,000 genetic instructions that comprise this virus. Remarkably simple. Hesitate to call it an organism. Are viruses a living thing or not? We could kind of debate that, but it's actually pretty simple. But the trouble is, there's mutations in these bases that code for the RNA, this ribonucleic acid genetic instruction manual. So this virus is made from RNA, just the same way as your genetics are made for all your body proteins are made from DNA. But with the virus, they've mutated, and when the genetic bases mutate, that means the amino acids also can change. And that changes the overall structure of the virus. So when a mutation arises that gives the virus a beneficial mutation, that will be selected in because that's the virus that will be reproducing, and the other viruses will be excluded out from that. So these variations are genetic variations. We can trace that with the genetics. We can trace it to an extent with testing, but really we need this proper, what we call genomic testing to identify that. And that's what's so clearly been identified in this Delta variant. There's a few changes actually in this Delta variant. One is called the spike protein, which is where the virus actually fits into your cell or my cell, the person it's going to infect. And that makes it easier to get in. And as well as making it easier to get in, it means that the virus can reproduce more quickly. So what we're finding with this Delta variant is people have a much, or at least they shed a much higher viral load. So some studies have shown, and it's hard to get your head around this, but some studies have shown that someone who's infected with the Delta variant can be chucking out hundreds of times more virus. Hundreds of times, literally, than someone with the old type variants. In fact, one study showed it could be 1,000 times or more. They're putting out very, very high amounts of virus. So whereas with the original virus, we used to say close contact constituted being, say, less than 6 feet away from someone for 15 minutes, now close contact is passing in a corridor. It is so much more transmissible. So there's cases in Australia, I think it was, where people literally passed in a corridor. And they had the CCYC, the what do you call it? The TV monitoring, the
CCTV, closed circuit television, yeah,
the TV monitoring, and it showed that the only contact that people had was when they passed in the corridor. And we've had cases in the UK and Denmark as well, where this seems to be transmitted outside at the football. So if someone's inside, they can transmit this variant really quite readily if they're inside. And of course we're getting that now because it's too hot, so people are put on the air conditioning and shut the doors, and or if it's too cold outside, you shut the doors and put the heating on, and it hangs in the air for a long period of time as well. The virus has always hung in the air for a long period of time, but because it's so much more viral load, it's almost as if instead of having like one infected person in the room, it's like you have hundreds of infected people in the room all breathing this virus out. You get very high viral loads.
So that leads me to my first question, really, because listeners have been asking, so many offices here in the States are returning back to work.
Yep.
I have listeners that are going to workplaces with thousands of people where vaccination is we'd like you to get vaccinated, but we won't make you, right?
Yep.
And these are open office plans, thousands of workers, factories, all this kind of stuff.
Yep.
When you tell me this hangs in the air, this gives me a lot of concern versus earlier in the pandemic where, well, if you keep people, keep things ventilated, you kept some space, kept people separate, you could do things. If it's spreading like you're saying,
it is.
I feel like something like, say, a factory or a large mortgage firm or a bank or any of that stuff, it could just spread like that.
Absolutely. I mean, we were already seeing that with the wild type variant way back in last year. We saw it even more with this Alpha UK variant, and now we're seeing it even more with this Delta variant. I mean, if you've got someone who is in their active viral secreting stage, so if someone's going to be symptomatic, then typically they're excreting most virus the day or two before they become symptomatic and the first few days after they become symptomatic. They're chucking out a lot of virus. It will hang in the air. And unless the ventilation's absolutely brilliant, if there's an infected person there shedding the virus, basically the transmission is pretty well guaranteed. And there's just been a report from the US Centers for Disease Control yesterday. In fact, it's a leaked report. It's just come out. I'm just assimilating it now. But people that have been vaccinated, even if they've been doubly vaccinated, still get infected with this Delta variant. Now, they're largely protected. They're very unlikely to get sick. They're very unlikely to get hospitalized, and they're very unlikely to die, but they will get the infection. And they'll chuck out a lot of virus so they can be spreading that to unvaccinated people. And what concerns me about the States at the moment is you've got over 100 million people in the United States who are eligible for vaccination but have not had one single dose of vaccine. Now, in the UK, the whole population is about 66 million. So you've basically got another 100 million. You've got a whole nation of people there who are unvaccinated. They're going to be mixing with people who are vaccinated and people that are unvaccinated, both of whom can get this, both of whom can excrete large amounts of viral load. And these people are going to get the infection. Now, the people that are vaccinated are going to get the infection as well, but they're 10 times less likely to get sick. About 96% protection with 2 doses of Pfizer, roughly, and even greater protection against death. But the people that are unvaccinated are going to get this infection, but their immune system is going to have essentially no immunity at all to this virus. Now, a few of them might have picked it up and not realised it, maybe 15 to 20% of them. But that still leaves 80 million people with no protection against this virus at all. They're going to be exposed to it, and therefore they're going to get it. And if they get it, there's a good few percent chance it's going to make them sick, especially if they're older, especially if they have comorbidities, especially if they're immunocompromised. So what's going to happen in the States, I don't see any way around this. And I'm really sorry to report it, but I don't see any way that it's not going to follow a similar trajectory to the United Kingdom with a dramatic increase in cases. But because the United States has got a larger proportion of unvaccinated people, a lot of these people are going to get sick, and unfortunately quite a few of them aren't going to be with us in a few months' time.
John, this makes me feel something emotionally, because only 40%, we just crossed the threshold in the city of Detroit. Only 40% of our population is vaccinated. We don't have access to healthcare. We are in a group, a lot of people like to label the unvaccinated as one thing. It's really not. Like, for instance, the biggest hesitation to vaccination in the United States is people who do not have, health insurance. And I know this is anathema to you or unfamiliar to you in the UK, but lots of people here, even with some of the government programs that have extended, they still don't have health insurance, or they don't have affordable health insurance. And so if they're not familiar or dealing with the medical system, and you have large sections of people in our country, especially African Americans, who don't deal with the healthcare system. And I know how many friends I lost in the first wave. And when you said that, my heart sank. And then I matched that with some data that I saw out of San Francisco that showed that even there, it's like 80% vaccinated, right? And it's they're in their second highest wave. And I sit here and I go, I don't want to be Chicken Little. I want to arm people with the tools to do what they need. And that's why I have like this list of questions from listeners, because this situation is moving so fast and they don't feel like they're getting everything they need.
Sure. I mean, you've got to differentiate between areas like Detroit at 40% and areas like that part of California with 80%, because so many more people are going to get sick and hospitalized where the vaccination rate is low. Now, from what we know from the Centers for Disease Control, the infection rate's probably going to be quite similar. But the point is, the people who are vaccinated are protected, 10 times less likely to get severely sick, about 96% less likely to go to hospital, and probably 98% less likely to die. Now, it really concerns me, the African American population in the States. Now, I identified last year that the African American population has got lower vitamin D levels than the white population, because simply dark skin makes vitamin D more slowly in the sunshine.
Well, there's also the fact of economic differences here too. Right. So if you, I don't want to discount the idea that, there is the point that you're making, but also when you're only making $30,000 a year as a household, you're much more focused on sustenance foods, things like that, and you don't have, as much access to grocery stores, all that kind of stuff. So I want to make sure it's multifaceted. I don't want to leave it at just skin color.
100%, Joe. Yeah. I mean, and as well as that, of course, that poor diet feeds through into things like obesity, diabetes, hypertension, and all these things that disproportionately affect that population. So healthcare is always multifaceted. There's the endogenous factors from inside, there's the multitude of exogenous factors from the outside, and they all play together. The reason I mentioned the vitamin D one is it's just so easy to correct. You can correct it with a pill. It's just, things like this are just not being done. And I really find that a problem. What I'm not sure about, Joe, is that the 40% in Detroit, is that central Detroit? Because my impression of Detroit is it's fairly poor in the inner part and more affluent around the suburbs. Is that kind of roughly where we're at?
Yes, that is where we're at. So the city of Detroit has its own numbers within the city, what we call the city proper. And then you've got the individual counties around it that report. And the individual counties that around it report higher vaccination rates,
right? The
highest being in Oakland County, which also is by far our most wealthy county, and a county that is more wealthy than some small states. And so that's it. It's so much inequality. All the inequalities of healthcare in America are showing out through this pandemic.
It really is highlighting this inequality problem that's always been there, that people have always known about. but it's just throwing it in people's faces now, isn't it? It's making it so obvious. And I'm just hoping that this is going to be the, well, what do we need? Political motivation, society motivation, individual motivation to start correcting these inequalities. Let's hope this is a bit of a wake-up call, because this is absolutely true. I mean, I've been doing a series from a friend in Africa, for example, and it's so obvious that there's these disparities between countries, but here you're talking about disparities between sort of downtown Detroit and the suburbs, and they're just waiting there to be identified and corrected. I couldn't agree with you more, and I really hope that's going to be done.
So there are multiple things I want to make sure that people know about. You mentioned about vitamin D. What can be the impact of it? Now, to be clear, this is not going to prevent you from getting the virus.
Oh, no.
Right. Let's be 100% clear about that, because there are so many rumors, especially, I don't know how it is in the UK, but over here, there's so much misinformation and disinformation and unclarity. And also you mix in with that, to be very honest, fear. You got a lot of people, America, we're a nation that we are used to, we're the superpower. We're used to having access to everything, and we're not used to these kinds of threats. If you think about even World War II, we had some bombs on Hawaii and some attacks in Alaska, but we never got hit, right? So we don't have our culture hasn't internalized these actual physical threats to us.
I think that's true everywhere. I mean, we've got used to this idea that if you get sick, you can get some antibiotics, and we've got away from this idea of infectious diseases. But, throughout human history, infectious diseases have been the big cause of death. If you think about the First Nation Americans, for example, they were completely, decimated isn't enough. It was more than 10%. About 90% of them died from smallpox. There's been this, we had this Black Death it's famous in my country, 1348, and the Great Plague of London in 1666. We were kind of brought up on this, but people just don't have this kind of concept now, and this idea that there's an infectious disease which is not immediately treatable is kind of hard for people to get their heads around, and that's part of the problem. We need to kind of adjust to that and realize that this is a real threat, especially in poorer populations where, as you say rightly, for various reasons, there's reduced immunity, higher death rates, and a greater amount of risk. I think with the vaccines, Joe, one of the things is people are so focused on the risks of vaccine and the possible side effects of vaccine. Now, of course, they're there, but they're there with any vaccine, any medication. Those risks are there, and overall, that they are pretty small, especially with the safeguarding that's put into the vaccination program in the United States, for example. Those risks are pretty small. I think we need to sort of think that the glass is half full rather than half empty. We need to look at the benefits of vaccination. That this is going to stop you getting sick, or very likely to stop you getting sick. It's going to stop you getting in hospital, and it's going to stop you dying. And over time, if you're not sick, it's going to reduce the spread of infection to those around us as well. It's the whole community thing. We need to just suppress this virus any way we can. Now, there's different views on how this can be done. But the bottom line is, at the moment, antivirals are not readily available, whether that's for political purposes or scientific purposes. They're not. We're not using them. So the tool we have available is vaccination. That's...
You were mentioning antivirals. That leads me to a question a couple listeners had. I have listeners who will never, they've straight out said to me, they will not get a vaccine. Yeah. And so they were saying, well, what about things like ivermectin and stuff like that, where they hear about these things on podcasts or different places. And to me, it's I'm trying to meet people where they're at. To me personally, it's very difficult for me to say, okay, I will never get a vaccine. What am I going to do? But like, is that a viable path? Is vaccines the better path? Like, how does that all shift together?
Yeah, that's right. I mean, just before I answer that, I think with the increasing cases and hospitalizations in parts of the States now, I think the vaccination rate is just starting to pick up in the States now. So I am optimistic it will pick up. It's plateaued for a long time, but I'm fairly hopeful it will pick up. Now, to me, this is completely obvious. We want to prevent disease, of course, and if we can't prevent it, we want to treat it. And if we get a bacterial disease, we would take antibiotics and treat it. The question is, do we have antivirals? Now, traditionally we haven't had many antivirals. We've had viruses for a few viral conditions, such as cold sores. You can get acyclovir for herpes simplex virus. But this drug ivermectin that you mentioned, it is revolutionised many parts of the poorer world by treating parasitic diseases, river blindness, and where you get bugs growing, not bugs, but organisms growing in the lymph nodes that causes the legs to swell up and things like that. It's completely revolutionised that, and treating scabies. But then a few years ago, people realised that ivermectin also had antiviral properties. Now, the problem with this is there's been a lot of debate about it on both sides. Now, I've read a lot of the information on ivermectin, and I've talked to some of the main people on it, like there's Dr. Tess Laurie in my country, who's a South African doctor, and of course you have Pierre Corey, who I've also interviewed in the United States with the FLCCC. And looking at that and talking to them, there seems pretty strong evidence to me that ivermectin would be effective as a preventative and as a treatment. Also talking to medical friends in India, that they've been using it. It was part of the India protocol to use it in India. They had a particular indication for it. They were using it for people with COVID-19 to stop them deteriorating. And the consultants I talked to, they told me it worked. Now, while they can't put necessarily numbers to that, if doctors are telling me, look, this is working, then, if you're not going to listen to your doctors, who are you going to listen to be quite honest? But then this got all complicated. So industry was saying, don't use this for COVID-19. Now, you can understand that, because I take care, and I'm sure you take care, never to say I'm advising taking a drug. I never do that. I always say go to your own doctor. Never, ever take a drug because I say so, obviously. And I think the pharmaceutical companies, because the drug was passed for one thing and not for the other, they didn't want the risk of comeback on them.
Liability.
I think so. Which is understandable. These are companies, they're there to make money. But then the World Health Organization came out against ivermectin, except for the use in clinical trials. Now, I consider that the data that is there indicates, and I'm going to choose this word carefully, probable efficacy. So I'm not saying possible, I'm saying probable, and I'm certainly not saying certain. And we have started a new clinical trial in the UK at the moment. But there's a lot of data out there. There's meta-analysis being conducted. And what really disappoints me about governments, and that, well, at the moment, the FDA, CDC, I'm not sure which one it is, have got a neutral rating on ivermectin. They're not saying it's good or bad. And the UK was saying don't use it. Basically, it's impossible for our doctors to prescribe it here. It's just, they just basically can't do that. We need from FDA, CDC, British authorities, World Health Organization, definitive statements, but not just definitive statements, backed up by the evidence. So if the World Health Organization says, look, we've looked at ivermectin, we're satisfied it has no role at all in SARS coronavirus 2 COVID-19 disease, here's the evidence, fine, we'll accept that. But they haven't provided the evidence that they're basing their decisions on. We need, I'm just an ordinary bloke, the same as you. Any practitioner is just an ordinary man or woman. We don't have access to all these things. We don't have all these skills, but we need to be guided. But we need to be satisfied that the people that are guiding us are doing it on the evidence, and they need to provide that evidence.
And I believe there's a number of clinical trials going on right now too. Like I was looking, doing some research. I think there's something close to 70 of them right now, which is a good sign. I think the fear with some, and I'm sorry to interrupt, I apologize.
No,
that must be the lag. The fear is that if you talk, or if you put too much out there, the fear is you've got people who are going to crack open their pets their pets medication or something, right? And that's what we don't want happening. Correct. And the thing is, here in the United States, we've got some incidences of that. We got some incidences of when people get a treatment that someone talks about publicly, they're so wanting something to do it that they go to desperate measures. And that's what we want to prevent against. So it's like, we need to evaluate this and see if it's something that's good for us. But we also need to be very cautious that a lot of people in the world are looking for that thing. They're looking for that thing, right? And just the question I had, can I take ivermectin instead of getting the vaccine? Well, I don't believe in the United States you even can, right? Like that's not even an option.
I don't believe that's an option in the States, no. There's a very good question there, is people that aren't vaccinated in parts of the world where the vaccine program is not available, should they be doing that? Now, the answer to that question is, I don't know, but we need this definitively. I think there's enough evidence to suggest the probability of that these agencies and our greaters and betters should be making definitive statements on this. And I really feel there's been a severe dearth of leadership here, because we should take drugs when our doctors or our nurse prescribers or whatever it is tell us to take it. But they follow national guidelines. I think it's the same in the UK. So in the UK, in the United States rather. So in the UK, we have these NICE guidelines. And you can understand this. So a doctor will prescribe by the NICE guidelines. Now, if he goes against the NICE guidelines and something were to go wrong, then all a lawyer would say to him was, were you following the NICE guidelines? And if he says, no, I wasn't following the NICE guidelines, then why weren't you following the NICE guidelines? It's nurses and doctors need this kind of support as well. The things need to be made official. That's why we have governments. That's why we have elected officials to take responsibility. And at the moment, it just seems that they're not. And I think it's a real pity, because I want to prevent disease, and if at all possible, I want to treat it as well. Having said that, there's quite a lot of research going on from some of the big pharmaceutical companies on new antivirals that are probably going to be out pretty soon. I think, not quite sure about this figure, I think it's $3.2 billion has been provided by the American government for antiviral drug research.
Yeah, and I wanted to mention also monoclonal antibodies, because I know of personal stories. People in my family have been treated by monoclonal antibodies, and it was very successful for them. Someone I know who was a senior citizen, so this was before all the vaccines hit, and it was something that really improved their situation. However, the rigmarole to get a hold of those, and I learned so much about how they're not widely available in case you end up in that situation. The only way that she got them, she was at one of our top 2 medical facilities in the entire state. Why isn't this more available for yes, absolutely. We're looking at this continuum of prevent things like, let's do vitamin D, let's do these things to help get us ready but also if we're going to get it, or if we end up getting it, having all the tools at our disposal to handle it. Because I look at this as a continuum, and I feel like this conversation for so many people online is about one thing, and it needs to be a continuum.
Yeah. So monoclonal antibodies, basically people would use it as a treatment. The former president of the United States, of course, was famously treated with monoclonal antibodies when President Trump got sick. Now, the thing is that these monoclonal antibodies, monoclonal means mono, one type, that they come, and a clone is a genetic variant, like identical twins would be clones. So they come from one type of cell that produces these antibodies. And you have to get biological agents to produce these antibodies. So you actually produce the antibodies, you refine these antibodies, and then you give them to someone. Now, these are the same kind of antibodies that your body will produce itself, but of course it can take quite a few days or a week or two to produce those antibodies. Whereas if you're injecting it, they hit the ground running. So this is what we call passive immunity. You give antibodies, and it's a form of passive immunity instead of making your own. Now, the key thing about this is the studies on this have been a bit difficult to interpret, because the thing about COVID-19 is you're going to get the virus a few days before you get symptoms. Then you're going to get the symptoms. Then you're going to have the symptoms for maybe 5, 6, 7 days typically. But then the body's going to get rid of the virus after that. So if the body's already got rid of the virus, there's no point giving extra antibodies after that time to get rid of the virus that the body's already gotten rid of. So this is a phased disease. So the monoclonal antibodies would only be effective, as in President Trump's case. They were given about 24 hours after, in fact, I think less than that, after he was diagnosed. And they did seem to be highly effective. But a lot of the people that get sick with this disease, they're not getting sick because of the virus. They're getting sick because of the inflammatory reaction and the body's immunological reaction to this virus. And it's that inflammation that causes your air sacs in your lungs, your alveoli, to fill up with fluid. It's the same as if you twist your ankle, Joe. If you twist your ankle, it swells up. That's the inflammation. It's the swelling. And this time it's swelling inside the lungs. And that's not caused by the virus. It's caused by the immunological reaction to the virus. So if you had a drug which was specifically antiviral, or a preparation that was specifically antiviral, like monoclonal antibodies, what would you do? Would you give it to everyone who had the virus? Well, we know about 95% of those are going to be absolutely fine, because we can't really predict that well who's going to get sick. I mean, we know older people are more likely to get sick. People with comorbidities are more likely to get sick. So it would be a pretty tough call. And this drug's very, very expensive. So it wouldn't be practical to produce enough and give it to everyone. And then when people already get sick, it's too late for the monoclonal antibodies. At that stage, when people are already sick and they've already gotten rid of the virus, that's why the steroids are so helpful, because steroids are massively, massively anti-inflammatory. So yeah, the monoclonal antibodies is a good idea, right stage of the disease, but it's got those complications that go with it and great cost that goes with it. One thing I wanted to ask Joe that I wasn't sure about, we know that the vaccine's free in the States. Is testing free?
Yeah. In fact, my roommate just got tested 2 days ago.
Right, but did they have to pay for the swab being taken, or the whole caboodle, the whole kit and caboodle was free, was it?
It was all taken care of. It was something where it was I don't know the particulars in his case. He paid nothing out of pocket. He does have health care.
Right.
Right. And like, I know that there are lots of free testing centers all over the city. And so I have not heard any reports of people getting charged for them out of pocket at this time here. That doesn't mean that it hasn't happened. It's not something I have heard of.
Okay, that's reassuring, because that obviously would be a major disincentive for testing. And the actual testing in the United States at the moment is about 4 times lower, 3 or 4 times lower than it is in the UK.
Well, I will tell you that the state line for testing, when my roommate went through that routine test, the state phone line was overwhelmed, and they're like, we'll call you back.
Right. Okay.
You know, because it's not as, the testing facilities are not as smooth as it could be. And a lot of times these tests are picked up by employers. So a large employer will have a nurse or a facility that does healthcare, and then they'll do the test, there at the facility, or there's various churches, a lot of CVS's and Rite Aid's, drugstores, where tests are. It's very distributed. The plan with the administration as this pandemic was going on wasn't to say, okay, we're going to do this at hospitals, this and this. It was, okay, we're going to do this at your drugstore.
Right. Yeah. 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 As near the community as possible. Absolutely.
Yeah.
No, that's reassuring. Thanks for that. Yeah. What else we got?
One thing I wanted to talk about was the idea of vaccines going bad. And one of the things that caught my eye earlier this week was 400,000 doses are going to expire just in Michigan, just in our state. And it's frustrating to me that we aren't taking them, but that's my own personal opinion. But it's doubly frustrating to me that we can't, no other states want them because they don't have the demand. Right. And so it's something where, to me, I feel like there's so many places where if we're already there, why can't we find more ways? Are there more ways to internationally work together to say, absolutely, this goes from here? And you know what, even if a quarter of those 400,000 shots get used, it's better than none of those shots getting used.
Yeah. I mean, these videos I've been doing with Rafa in Uganda, he's a hands-on healthcare provider, and he hasn't been vaccinated yet. Not one single dose. It really is quite frightening. Now, what happens when manufacturers make any pharmaceutical preparation? They always put an expiry date on it, and with vaccines that's particularly true, because if you think of the Pfizer and Moderna vaccines, for example, they're basically this strand of RNA with a lipid capsule on it, and those chemicals, they store much better at colder temperatures, as we know, but they do tend to degrade. So the manufacturers always put an expiry date on it, and because the manufacturers don't want to get into trouble, they tend to put on an expiry date which is, some people might say it's a little conservative, but in healthcare, every time I give out a drug, I'll check it's the right dose of the right drug to the right patient at the right time via the right route, but I'll also check the drug hasn't expired. You absolutely have to do that, and if it's expired, we don't give it, because we simply would be operating outside the law if we did that. So the shelf life of vaccines, even if they're kept cold, is actually pretty short. So you need this kind of cold chain and this logistical setup. I mean, the United States started off very well with this. The military were involved, they had logistics spreading vaccines out. They were using FedEx and different agencies like that. But at that time in the States, of course, the vaccine supply was much less than the vaccine demand. Now in the States, because of your quite superb national production facilities, we're producing huge amounts of vaccine. You can produce huge amounts of vaccine more than people are ready to get it. So you have more vaccine than demand at the moment. And firstly, it would be good that if the demand was higher, but it is so. Well, you would need to anticipate this. If these vaccines were going to run out in, say, 2 weeks' time, then you could say, well, tell you what, we've got 2 weeks to get this vaccine to Uganda. Let's get it there now because this is going to run out. But, for whatever reason, as well as I do, that tends not to happen. And it's an absolute travesty. I completely agree with you. But that's why they do it. It's a safety thing.
Yeah, and it's a real travesty here because it's actually a point of pride for Michiganders.
Yeah.
One of the large Pfizer factories is in our state.
Yeah.
So many of the vaccines sent out around the world come from, I believe it's near Kalamazoo, right here in Michigan.
Right.
And so it's a big point of pride for a lot of us that this is a place that we're doing this, and there's so much healthcare. In fact, here in Detroit, although they've moved over the years, I think it's Park Davis was actually founded here, and like a bunch of pharmaceutical companies and things like that. So there's a lot of pride in that, but there's also the worry of, okay, why can't we just get it across the border? Although our friends to the north in Canada have been improving in vaccination far more than we have as of late. They've really catched up and overtaken us.
Well, they've well and truly overtaken you, as indeed they've overtaken the UK, actually. Canada is the second most vaccinated country in the world after Israel. In fact, they're probably going to overtake Israel probably any day now. They have done remarkably well despite a slow start. And that's despite there being no domestic vaccine production at all in Canada. Now, I think that's something they're addressing pretty urgently.
It also helps, though, that factory is not far. That's a few hours drive, right? That Kalamazoo factory, I think it's less than a day. You can drive it, over the border and get into Canada and get into that southern portion where most of the people live. I wanted to ask you, I don't know if this is the last question, but I wanted to ask you because I know so many people who are hesitant about the vaccine.
Yeah.
What's your pitch to take it?
Well, there's no question that we have to follow the national guidelines. Now, in the UK, we're only vaccinating over 18s at the moment, and people that are within a few months of their 18th birthday, and younger people with comorbidities. Now, the particular vaccine that's taken is a bit of a debate. So the Janssen Johnson & Johnson vaccine and the Oxford AstraZeneca vaccine, there was very rare incidents of blood clots and what we call thrombocytopenia in those, mostly in younger females. But for that age, we haven't differentiated between males and females in who gets what. So we've kind of put age categories on it. Whereas, and of course, the Oxford AstraZeneca vaccine was due to be rolled out in the States as well. But it hasn't actually been authorised there because you simply didn't need it, because you've got loads of the mRNA vaccines, the Pfizer and the Moderna, so you don't need the Oxford AstraZeneca. And there's of course there's slight risk. So you can get a sore arm, you can feel a bit ill after the first or more often after the second dose for the Pfizer Moderna. You can feel a bit knocked off for a few days. That's just because the body's mounting an inflammatory response, and it's as if you've got a little bit of the virus for a short period of time. But most people don't get that. Most people get absolutely minimal effects. Of course, there's a few people, a small minority of people that get severe allergic reactions. But again, we know how to treat that. Now, there's been a lot of talk about young men especially, the risk of this condition called myocarditis and pericarditis, which is inflammation around the heart. So I think it's a good idea to just rest for a few days after you've had the vaccine. And of course, if you had any clinical features that thought anything was wrong at all, you go and take medical advice on that. So, for example, if someone did have a bit of chest pain, it's very important that they rest and get medical advice. But it's the same whether you get a little bit of side effects from the Pfizer Moderna vaccine or whether you get a little bit of side effects from one of the adenovirus vector vaccines. The doctors now know about these things and they're much better about treating it. So, for the vast majority of age groups, certainly everyone older, the risk-benefit analysis of taking the vaccine is completely overwhelming. I mean, I just couldn't wait to get mine. I was here on the podcast. I haven't been vaccinated yet. Come on, vaccinate me.
Yeah, no, I was in line down at our mass facility, and it was kind of dispiriting to me because there was all this efficiency, and you can still walk in and get a vaccine. In fact, in the city of Detroit, you can call a number and someone will come out to you and give you a vaccine, right? Like it's that available. But right after that first rush of 30-40% or whatever, where we're really excited, then it just kind of petered off. And I think in that same vein, I think there's that portion of my listeners, and I know more of my listeners are going to be more friendly towards vaccines than not. How are they going to navigate all of this? Like a mask mandate, our governor, who was among the most aggressive in mask mandates, has already said a mask mandate is not coming. It's not coming. And I think about those workplaces. I think about when you say those outdoor spread. How do you navigate this if you are concerned about this? And I think we all have to accept there is no cavalry in the United States coming for us. There is no mask mandate in my state. You're not going to see it. If you're not going to see it in my state, you're definitely not going to see it in most states, right? Because our governor was among the most aggressive, right? We're on our own. So what do we do?
Basically, I mean, the CDC has got a lot of things you can say wrong about it, but it is the national authority. And the CDC has said a few days ago that people should be wearing masks in most parts of the United States, indoors at least, in indoor settings. And the reason they've said that, that's come out with this sort of leaked report that we've just had. And the reason for that is that people that, of course, before it was an honour system, wasn't it? You know, that people doubly vaccinated didn't need to wear masks. People that weren't vaccinated should wear masks on an honour system. But now we know that people who are doubly vaccinated can release, we believe, almost the same amount of virus as people that are unvaccinated. Much less likely to get sick, but they can chuck out a load of this virus.
Right. If they do get sick, if they are sick, they can spread the virus, right?
No. If they get the virus, they can spread it. And they can they can chuck out a lot of virus. So if you take someone who's vaccinated, they can get infected. They're still quite likely to get infected. And they will chuck out a whole load of virus. Now, that person themselves will not get sick.
So they might not even know they have it.
They may not. I'm glad you reminded me of that. The symptoms they're likely to get, the most likely symptom they get is a headache, which is the same as you get with a cold anyway. Headache, runny nose, sore throat, and sneezing are now the most likely features. And they're likely to get over that and think, oh, I've got a cold, I've got a bit of hay fever. But when they're excreting that, when they're chucking that virus out, they could give it to someone else who is unvaccinated or immunocompromised, and they could get really quite ill. We have this a lot in multi-generational households as well, or if someone's going around to visit parents or grandparents. If you had a situation where you had a young person who may be vaccinated, who go around to see parents or grandparents who are not vaccinated, then they can pass that virus on, and the unvaccinated older person or the person with comorbidities is really quite likely to get sick from this. And in fact, even if the older person, or you've got someone who's vaccinated or unvaccinated, they could still take the virus to someone who was vaccinated. They can still get the virus, but the vaccinated person is protected from 10 times less likely to get severely ill. So that's the reason I'm a bit pessimistic about the numbers scooting up in the States now, because we know that the vaccinated and the unvaccinated are both going to be spreading this disease.
Well, and the case numbers show that even in a low spread area, like right now, we are not in that red area from the CDC, but our case numbers show that even in areas that are highly vaccinated. I'm pulling up the numbers right now, and we're almost within a week. It's gone from about 3 cases per 100K, and we're now already up to almost 7 cases in Oakland County, which is that well-off, well-vaccinated county, right? So it's people are saying it's coming. I think, is it fair to say it's here?
Yes, it is. I mean, the Delta variant now is probably, I think the last information I saw from the CDC was the Delta variant was about 86% of the cases which are diagnosed in the States. But now I would suspect now it's well over 90%. So basically, the Delta variant, as in the UK, has taken over, and that means the numbers will increase. Now, in the UK, the good thing about it is, even though the numbers of cases increased dramatically, and they may be increasing again next week, they seem to be just starting to go up again now, hospitalizations are still relatively low, deaths are relatively low because of the protection against severe disease and death and hospitalizations that's afforded by the vaccines. And it really is, it really distresses me, Joe, that I think of so many people, and it's particularly, as you say, the people that are often disadvantaged that are going to suffer most. Just for a change, the poorest people suffer most. It's just.
Yeah.
We need to get that message through. You need to protect yourself and you need to protect your family. There's massive benefits associated with vaccination. Just get it. President Biden's right. Just get it.
Yeah. I mean, listen, this is a personal story, but I have a neighbor 2 doors down in the hospital for 30 days on a ventilator.
Yeah.
Thankfully she made it through.
Yeah.
But like, these are all real things. It's been in my family. It's something where I don't want what happened that first wave to happen again here. And I don't want it to happen to other people.
That person on the ventilator, they're not going to be fully well again for at least another year. There's going to be a long-term thing. And the other thing that, because there's so many cases now, we're getting a lot of cases. So in the UK at the moment, population of about 66 million. There's about 1 million people with long COVID at the moment, this long-term one. But the actual percentage is higher than that. And about 1/3 of 1 million people have had long COVID for over a year. So another really important reason for getting vaccinated is to protect yourself and your family against long COVID. Now, these are people that can't go back to work for 3, 4, 5, 6, 7, who knows how long this is going to be. They have a really low quality of life. They can't return to normal activities. They can't go out and make a living for their family. Because they're suffering from this long-term effect of COVID.
And to be honest, I think that's part of the issue that's happening here in the United States. Yeah. I don't know, you've heard with the lack of people finding employees has been a real problem here. Like, this is something that a lot of businesses are worried about because they can't get people to fill these positions. Well, the number one reason isn't unemployment benefits. It's the disease and worries about the disease and effects. And you took the different things with a survey that was done by a regional chamber here recently. Yeah. The number one reason isn't unemployment. It isn't that check. It's those worries about the disease. It's the I'm still dealing with effects, or people who have retired early because of the effects, right? Yeah, or the worries. And this is going to have, like, and I know we're talking the medical side, but as for me, as a more general reporter, I look at it in like a bigger case and I go, okay, we might not have mandates, but this could economically be really a problem if you have all of this spread and all of these issues and reverberate through the economy in so many ways. And if we're not having a lockdown, which I don't think we're going to have in the United States, and we're not going to have mass mandates, you're going to see more places, and this plays into the partisan divide where I joke almost, it's the like Dr. Seuss with the butter side up and the butter side down. Butter side up of, we're getting vaccines, butter side down, come in here if you don't have a vaccine, right? And that just spreads people apart even more. And that worries me for the fabric of our nation. The divisiveness, absolutely. The divisiveness where this is just straight up how it is. And you've got a portion of people who don't, they for whatever multiple reasons, they're not part of this. And you're going to end up with a lot of untold economic destruction. Our small businesses can't do another wave. Even if you don't lock down, let's say the 1/3 of people who are most concerned about the virus, not quarantine, but self restrict. Yeah. Right. Let's say I'm concerned about the virus and I don't go to a football match. I'm a soccer fan too. Detroit City FC, La Rouge. You don't go to a football match. You don't go to a football game like our American football. You don't do a bunch of these things. You're not spending money in the economy. Yeah. Who's going to hit most is those small businesses, and there isn't going to be the political support to help them like there was before.
No, and it's the effect on the individual. So you've got the most disadvantaged communities who got the least rate of vaccination. Therefore, they're going to get more disease. Therefore, they're going to get more long COVID. Therefore, there's going to be more people who are not simply well enough to go out and earn for their families, because there's going to be more long-term morbidity in those poorer communities. And that's going to accelerate this downward spiral, which is such a tragedy just to...
And it's all avoidable.
Watch. Yeah, well, 98% of it or so is avoidable. Yes, absolutely. Yeah.
Yeah.
Get that message out there, Joe. You're doing a good job.
Well, thank you, and I appreciate all of your time. And as I said, listeners will have to laugh because this is a little bit of a personal joy for me because I feel like I'm talking at the voice that's been talking to me through my television for 16 months. Frankly, I can't wait to go to the UK. My team is Nottingham Forest, by the way.
Oh, I used to watch those when I was a boy. Yeah, I just used to
okay.
Yeah. Small world, Joe.
A small world. Well, thank you so much,
Pleasure.
John. I appreciate you.
No problem. Thank you.